So, hi all, let's talk about the practical aspects of the reversal agents as we have already talked about the neuromuscular blocking agents, which lead to paralysis of the skeletal muscles and vocal cords, which facilitates the intubation of a patient. Now, when it is time for extubation, you have to obviously reverse the effect of the other of those agents. Now, for reversal, the most common agent that we use is our very own Neostigmine. The other agent, which is very much popular in recent times, and it is going to replace Neostigmine at some point, is going to be the Sugammadex. So these are the two agents that we are going to talk about. Sugammadex is a newer agent, much more expensive, not available in most of the centers. So we are still using Neostigmine. This Neostigmine comes in zero point 0.5 mg per ml of ampules, and the full name is methyl sulfate, neostigmine methyl sulfate. Now we know that the postsynaptic receptors of the neuromuscular junction, they are occupied by the neuromuscular blocking agents. Suppose this were the agent. This neostigmine is going to inhibit the acetylcholinesterase enzyme, which will increase the acetylcholine levels in the cleft. So suppose now acetylcholine has increased in this cleft. They are going to replace this neuromuscular blocking agents, and once they replace, succinylcholine is going to attach, and the nerve conduction will again start. So this is how it reverses this. So it is known as competitive antagonism. But the problem with this administrating the neostigmine alone is because of this increase in the acetylcholine that you can see. This can lead to other side effects because acetylcholine is not going to act only on the neuromuscular junction, no, but it will also act on the muscarinic receptors elsewhere in the body. So that will lead to side effects because of the increased acetylcholine. So even though it is helping us in reversing the effect, but because of the muscarinic receptors, it will have certain side effects which can lead to bradycardia, hypotension, bronchoconstriction, increased secretions. You all know that these are all the side effects of increased ACH, the parasympathetic activity of the body which increases. So all those side effects are because of this. So that is why, to prevent these muscarinic side effects, we need certain muscarinic blocker along with that. So that is why we use glycopyrrolate as an additive with the neostigmine, which is usually added at a dose of 0.01 mg per kg. So this is the muscarinic acetylcholine receptor. So we finally know why glycopyrrolate is added. But you may ask me, why only glycopyrrolate is usually added? Why not atropine? The reason is this, that the onset of action of the neostigmine and glycopyrrolate is 1 minute. So they are going to simultaneously act, and that is why they are usually mixed. So this 1 minute onset is the reason why glycopyrrolate is added with the neostigmine and not atropine. The neostigmine, as you can see, the dose is given in the dose of 0.05 mg per kg, or you can say 50 microgram per kg of body weight. But this is the usual dose. That is not necessarily the dose which has to be given. What do you mean by that? The answer is, reversal can be given either by looking at the clinical situations that we usually do, but the gold standard for this starting the reversal is the TOF ratio. This is a big topic. This is neuromuscular monitoring. So based on the TOF count and TOF ratio, you will decide what will be the dose of neostigmine. There is a table in Miller which clearly tells you at what TOF count and what TOF ratio you should avoid giving neostigmine altogether, because at deep block there is no point of giving neostigmine when once all the receptors are occupied by the neuromuscular blocking agents. You doesn't matter how much neostigmine you give, it still cannot move from their site. the competitive antagonism doesn't act. So in deep blockade, there's no point of giving neostigmine, and that's where the Sugammadex comes in play. When doesn't matter how deep the block is, Sugammadex can still reverse the effect. So this table will tell you at what particular recovery point you can give neostigmine, and if there's somewhat deep block and you can administer neostigmine, you have to give it in higher doses. Suppose the patient has recovered a lot and is about to gain his muscle strength, then you can reduce the dose of neostigmine. So those doses will depend on this TOF ratio. This is the gold standard of deciding the dose of neostigmine. Otherwise, we usually give it at a dose of 50 microgram per kg along with glycopyrrolate. That's what I wanted to tell you. Now let's see about these questions. And when do you start reversal? This we have answered, that clinically once you see that on the ventilator the patient has started breathing on his own, so that is known as once the spontaneous breathing efforts has come. So what you will do, you will put the patient on pressure support, you will keep on reducing the pressure support, and you will try to increase the trigger. So slowly and gradually it will what will happen, that you will reduce the pressure support till 8. This is the most common scenario that I'm talking about, and the trigger comes to 3. Usually you can try to attempt for the spontaneous mode. Now if the patient is breathing or even on the spontaneous mode, or it has at least reached this stage where the pressure support has reduced to 8 and is generating a good tidal volume of about 4 to 6 ml per kg, that is when you can realize that he is gaining enough of the power in the diaphragm muscle and is generating that much of tidal volume at a pressure support of 8, and the trigger has increased till 3. So the patient is making sufficient recovery and you can start giving reversal. Now this reversal, whenever it is given, it has to be given slowly. It has to be given over 2 to 3 minutes. Why? What is the reason of giving it slowly? That we already know that if you're not giving it slowly, these side effects like bradycardia. I have seen patients getting bradycardia. The heart rate was 90 and you started reversal and the heart rate suddenly come to 50 and then 50. So this is the reason why we give it slowly and we add glycopyrrolate with it. Now you must have seen in real life that even after giving certain dose of reversal, which is usually calculated in the ratio, suppose 60 kg person, you calculate it as 6:3. That means 6 ampules of neostigmine and 3 ampules of glycopyrrolate. 50 kg person, 5:2.5. So this is a shortcut to calculate the reversal dose. Now, and it is obviously based on the fact that neostigmine is given in the dose of 50 microgram per kg and glycopyrrolate is given in the dose of 10 microgram per kg. Now leaving it aside, suppose you have given this adequate reversal dose, still the patient is not coming out of the effect and you want to give repeat reversal, or you want to give a bit of more of the reversal. Now, is there any problem with this? You can keep on giving reversal, you can keep on repeating reversal. What may happen? Obviously, the side effects of bradycardia hypotension, they may occur, but additionally, repeating reversal may actually cause cholinergic crisis because you're inhibiting acetylcholinesterase enzyme and increasing ACH. If you are repeating or giving excess of reversal, this acetylcholine will increase too much and will act like a depolarizing block. You must have read about succinylcholine. This is the mechanism of action of succinylcholine because it repeatedly stimulates the motor end plate and that will make the receptors in a depolarized state, that will lead to paralysis of muscle. This is known as paradoxical paralysis. So remember, neostigmine should not be given in excess, should not be repeated too frequently. Then suppose you still want to repeat and you have high suspicion that there is no other cause of the patient not coming out of the reversal and you want to repeat it. If you have made the decision of repeating it, remember the peak effect of neostigmine comes in 6 to 10 minutes. So before 10 minutes of giving the first dose of reversal, you should not repeat it within 10 minutes. 10 minutes is the minimum time that you should give for repeating another dose of neostigmine. Don't be in a hurry of repeating neostigmine because there may be other causes of patient not coming out of the reversal. And the duration of neostigmine is 2 to 4 hours. Then we come on to the last important question of neostigmine: how the process of reversal different in adults and pediatrics. Remember, pediatrics patients have a high parasympathetic tone. That means they already have a high propensity of developing bradycardia because the heart has more of parasympathetic supply. So they already have a higher parasympathetic tone. They are more prone to bradycardia. If you give neostigmine to them, they may get into cardiac arrest very fast. So that is the reason in neonates it is a dictum that you give atropine in place of glycopyrrolate, and you have to give it prior to giving neostigmine, because if you give neostigmine within 1 minute it will have its effect and the patient will have bradycardia. So give atropine first followed by neostigmine. Similarly, if the child is suppose an infant or 2 to 3 year old child, they still have a higher parasympathetic tone. So don't give atropine, but give glycopyrrolate first. Give it first. Don't mix it with neostigmine. Give it first, and then after some time give neostigmine. So this is the reason why we are not adding neostigmine and glycopyrrolate or neostigmine or atropine in neonates. That's all, I guess, is the important aspect in the neostigmine. Let's get to the newer drug, which is Sugammadex. It comes in aqueous solution, and in a vial, 2 ml vials or 5 ml vial, it contains 200 or 500 mg. What is the mechanism of Sugammadex? It is like a circle. It has a lipophilic core and a hydrophilic periphery and a lipophilic core. In this core, it actually entraps the neuromuscular blocker. So it will encapsulate it, and then it is excreted as a water soluble complex in the urine. Remember, Sugammadex has no metabolites. It is not metabolized. It is directly excreted in the kidney, unchanged. That is the reason why we should not give Sugammadex in renal failure patients, but we can easily give it in liver failure patients, because it is not metabolized by liver but is excreted by the kidney. Now the usual dose of this Sugammadex is 2 to 4 mg per kg, but even if the patient has is in a deep neuromuscular blockade, suppose you have just given rocuronium, within 10 seconds, suppose you're not able to intubate, it is quite a possibility. Suppose in a rapid sequence induction, you tried to avoid succinylcholine, because succinylcholine doesn't have a reversal agent. Sugammadex along with the rocuronium is a very good combination. So once you give rocuronium, suppose you're not able to intubate, then you can give Sugammadex at a dose of 16 mg per kg, and within seconds the patient will come out of the effect. So you can actually avoid a condition of cannot intubate, cannot ventilate, because you can now because the patient can get his spontaneous breath now once you have reversed the effect. When you have so much of advantage with Sugammadex, there has to be certain side effects. The side effect is again marked bradycardia. However, it is not because of increased acetylcholine, similar to the neostigmine, because neostigmine inhibits acetylcholine esterase enzyme that will increase acetylcholine. So because of the increased acetylcholine, there were marked bradycardia. But here This marked bradycardia is rare in Sugammadex but can be seen. There's a risk of coagulopathy and bleeding. So, in a patient of raised INR, try avoiding reversing the patient with Sugammadex. Again, in renal impairment of the patient, suppose is on dialysis, don't reverse the patient with Sugammadex. Now, because Sugammadex, once given, it can recover the patient very fast, and the patient has still have endotracheal tube in his mouth. So this patient, uh, because the vocal cord movement will start, and these vocal cord, they are going to hit against the endotracheal tubes, the patient will feel uncomfortable. The patient will start to buck. So as soon as you give Sugammadex, which is a good thing, that reversal will be faster, but still the tube is in situ, so these airway problems may occur because of the anesthesia wearing off. Then anaphylaxis is very common with Sugammadex. Remember, in anesthesia, muscle relaxants like vecuronium, rocuronium, they are the most common agents for anaphylaxis, which is very surprising because you're using it so often. But yes, this is a fact that neuromuscular blocking agents are the most common cause of anaphylaxis. Now, suppose you gave rocuronium and rocuronium had a reaction. Now you suspected anaphylaxis by clinical signs or the monitors, and you want to reverse with Sugammadex. This is quite funny that even Sugammadex itself has a high propensity of anaphylaxis. So you wanted to reverse the rocuronium, and obviously that will reverse the anaphylaxis. But suppose if the patient is allergic to Sugammadex also, then instead of reversing the anaphylaxis, it will exaggerate the anaphylaxis. Then last side effect is it may reduce the contraceptive value. So in young patients who are taking oral contraceptive pills or certain contraceptive contraceptive agents, if you are using Sugammadex, there may be a chance of failure of that contraceptive. Role in RSI, we have stated that succinylcholine doesn't have a reversal agent. There may be a possibility of phase 2 blockade, or maybe a atypical cholinesterase enzyme which may prolong the action of succinylcholine. So better to use rocuronium, and suppose some problem occurs, you can easily reverse with Sugammadex. In pregnancy, Sugammadex being a larger molecule cyclodextrin, it doesn't cross placenta. So pregnancy it is very safe. You can give it safely. In cardiac patients, in pulmonary disease or liver disease, you can give it safely. But in pediatric patients, less than 2 years, it is contraindicated. It is actually not recommended in less than 18 years of age, but still 2 to 18 years people are using it unofficially. But less than 2, no one does it. For CKD patients, you have to avoid it because it is excreted unchanged in the urine. That's all with these two agents. Try to remember, try to watch this video again and again, try to consolidate what I have told, and you will never face an issue with using these two drugs.